Great. Thank you, Sean. First, I really want to thank everyone in the room, everyone here at the Institute. It's really worked hard, and we have a great team helping us get these cases on and on time. We have an interesting case. I'm going to have Peter Biegler, our fellow, go ahead and go over the vignette on this particular patient.
Thank you, Dr. Pena. Good afternoon, everyone. I'd like to present our next case of a lifestyle-limiting claudication. Next slide. Disclosures as listed. Next slide. Our patient is a pleasant 64-year-old gentleman with right lower extremity claudication. The patient has been experiencing this claudication over the past 5 years that has been slowly worsening and now limits his normal activities of daily living. The patient has tried an exercise program over the past several years without success. He has also been treated with Cilostazol with no improvement. Next slide. The patient's history is significant for peripheral arterial disease, for which he was treated for left lower extremity claudication in 2006. We ended up doing a recanalization of a chronic SFA occlusion on the left side with stenting. The patient is also currently smoking despite cessation attempts. He also has a history of coronary artery disease, diabetes, and hypertension. Next slide. The patient is currently being treated with aspirin and Plavix in addition to statin medication. Next slide. On physical exam, the patient doesn't have any symptoms of acute ischemia in either lower extremity. His pulses are palpable in his common femoral arteries, and the pedal pulses on the right are Dopplerable and palpable on the left. Next slide. Non-invasive imaging was obtained and shows no arterial insufficiency in the left lower extremity where our previous stent was placed. However, on the right, we have some dampening of the waveform below the knee, suggesting some femoral popliteal disease. This is also further characterized on our ABIs, which demonstrates significant decompensation after exercise to an ABI of 0.32. Next slide. Duplex ultrasound demonstrates triphasic waveforms in the right common femoral artery with a high resistive elevated peak systolic velocities in the distal SFA with post-stenotic waveforms distally. Next slide. CT angiogram was performed, and our MIP 3D reformats demonstrates extensive calcified atherosclerotic disease throughout the lower extremity vessels in addition to some mild dilatation of the distal aorta. On the left lower extremity, you can see our stent, which is patent along the left superficial femoral artery. On the right, we have multifocal calcified disease in the mid and distal right superficial femoral artery with two-vessel runoff via the anterior and posterior tibial arteries. Next slide. Curved planar reformats further demonstrate our stenosis in the distal superficial femoral artery on the right and a patent stent on the left. Next slide. In summary, we have a 64-year-old male presenting with lifestyle-limiting right lower extremity claudication with plan for endovascular treatment and evaluation of the right superficial femoral artery.
Great. Thank you very much, Peter. So this is a pretty interesting patient that we've been